very important. And then we'll talk about what like a typical cycle is like at our program. So why is IVF itself a relatively inefficient process? And the answer to this is really age-related aneuploidy. Even the best-looking embryos can be aneuploid and have no meaningful reproductive potential. Chromosomal aneuploidy is a significant contributing factor in both implantation failures as well as spontaneous miscarriages, and is likely responsible for the majority of IVF failures. So patients often compare IVF programs based on success rates, which then incentivizes physicians to take measures to boost their own pregnancy rates. As a result, these physicians and patients have a preference for transferring more embryos. This then increases the risk of twin as well as high-order multiple pregnancies, which then increases the risk of both maternal and neonatal complications. And the societal cost for caring for these preterm neonates resulting from these multiple gestations outweighs a couple savings from preventing a failed cycle. And the couple often chooses a transfer strategy that minimizes their own financial burden while assuming the increased medical risks and adding to the overall health care costs. Thank you. So how can we prevent multiple gestations? Well, a multiple gestation is almost entirely preventable with transferring a single embryo. And here's data taken from SART, which is Society of Assisted Reproductive Technology, which is where the majority of IVF programs in the country, in the United States, report to. And SART is always 2 years behind because it requires live birth outcome data, and so that's why it's always going to be 2 years behind. So this is data from 2013 looking at single embryo transfers. So in 2013, in women under 35, a little over 22% had single embryo transfers. 35 to 37 is about 14%, 38 to 40, a little over 6%, and 41 or greater, 4 to 5%. So obviously, it's not where we want it to be.
Do we see the increase is greater than 40% for donors?
Well, in donors, typically we only put back one embryo. When we're using donor eggs, we're only putting back one embryo these days. And if you look at data from the last few years, you actually see an increase in single embryo transfers, especially in under 35, which I'll get to in a second, because the recommendation is to put back one embryo. But if you look at, we don't have that data yet because it's 2 years behind, but it's definitely much better than it was in 2013, but not where we want it to be yet, and we'll talk about how we can get there. So there are guidelines set forth by ASRN, or the American Society of Reproductive Medicine, in terms of how many embryos to put back. And we, in our program, we only put back blastocyst embryos, so on day 5 or day 6. So in women under 35, the recommendation is to put back one embryo, and these are unscreened embryos. 35 to 37, you could put back 2 embryos. 38 to 40, 2 blastocysts, and 41 or greater, 3 blastocysts. And they do give you a little wiggle room in terms of an unfavorable, prognoses where you can put back an additional embryo. So these are guidelines for unscreened embryos set forth by ASRM. And the reason for this is the older you get, the less likely you want to get pregnant, so you're more typically put back more embryos, which is the problem and the risk for multiple gestations. So reluctance to accept a single embryo transfer likely stems from the diminished chance of success when only a single embryo is transferred, reflecting the inadequacy of current methods of embryo selection. With a single embryo transfer, the entire cycle outcome is dependent on the fate of the selected embryo. Embryo grading has both inter as well as intra-observer variability and has not been shown to correlate with chromosomal status. And extending embryo culture to the blastocyst stage improves outcomes from a single embryo transfer, but a morphologically normal blastocyst retains significant risk of aneuploidy. So even normal embryos, normal-looking embryos may be completely abnormal chromosomally. And if an aneuploid embryo is selected, there's no chance of delivery of a healthy newborn. And aneuploidy is a leading cause of implantation failures as well as miscarriage in IVF cycles. And as I mentioned earlier, well, I'll get into a little bit later on, aneuploidy increases with increasing maternal age, and we'll talk about that a little bit more specifically later on. So when it comes to aneuploidy screening, in the past people used to refer to this as pre-implantation genetic diagnosis, or PGD, which is really a better term for screening for genetic disorders like single gene disorders such as cystic fibrosis, Tay-Sachs, Canavans, etc. So PGD is more single gene disorders. So the more appropriate term is pre-implantation genetic screening, or PGS, and what we commonly refer to as CCS, comprehensive chromosomal screening. And this enables the assessment of the numeric chromosomal constitution of the embryos prior to undergoing an embryo transfer. And CCS identifies a chromosomally normal or euploid embryo. So when you have a chromosomally normal and euploid embryo, this results in increased implantation as well as ongoing pregnancy rates. And because of this, this enhances the utilization of a single embryo transfer. So if you're more likely to have a normal embryo, you're more likely to undergo a single embryo transfer. When you have a chromosomally normal embryo, this also reduces the time to pregnancy. So instead of doing an IVF cycle where you put back unscreened embryos, which may result in a failed pregnancy or even a miscarriage, and then by the time they start a new cycle or they're pregnant, they then miscarry, start a new cycle, when you put back a screened normal chromosomal embryo, they get pregnant at a faster rate. So the time to pregnancy is much faster. And we had a meeting yesterday, and we've been pulling data looking at it from the time that patients start seeing us to the time that we discharge them to the OB. And because most of our cycles involve putting back screen embryos, no study has done this before, but it's amazing the time to them being discharged to OB is much, much quicker. It's it's a few months by the time they start to they then graduate. And they're looking to put together some abstracts and oral presentations at the ASRM meeting, which is coming up in a few weeks. So when you also have a chromosomally normal embryo, this also decreases the chance of miscarriage. And the ability to prevent an aneuploid pregnancy allows patients to avoid the physical as well as emotional suffering of miscarriage, and is really a more patient-friendly approach. Now, I can't stress enough how appealing this is to patients, to prevent a miscarriage, especially if they've had even if they had one miscarriage, or obviously they had a history of recurrent miscarriages. The ability to prevent that miscarriage, is very appealing to our patients. So most initial studies on aneuploidy screening involve biopsies of a single blastomere from a cleavage stage embryo, so a day 3 embryo, and it utilized FISH technique, or fluorescence in situ hybridization. And this provided very disappointing results. So the reason FISH didn't work so well, it was very inaccurate. There was a lot of subjective error or human error in interpreting the FISH probes which lit up when they looked under a microscope. There's a lot of subjective error. You also looked at only a few chromosomes. There was more mosaicism. And you only looked at one cell. You took one blastomere. And as we'll get to later, it was actually more traumatic to the embryo when biopsying the embryo on day 3. So now we have validated testing platforms capable of analyzing all 24 chromosomes to assess the ploidy status prior to selecting the embryo for transfer. And the variety of different methodologies that we have and are in current clinical use. And these include array CGH, which is array comparative genomic hybridization, metaphase comparative genomic hybridization, SNPs, which are single nucleotide polymorphin microarrays, qPCR, which is quantitative rapid real-time polymerase chaser reaction, which is the platform that we use. And probably the next big thing coming down the pipeline is next generation sequencing, or NGS. And there's a lot of investigations undergoing with this. And the reason it's very appealing is increased throughput, and it may allow for simultaneous evaluation of single gene disorders, translocations, abnormalities of mitochondria, and also it may lead to reduced costs. And it's basically, you're going to be able to put a lot of patients' data on one chip and run it much faster. So it's going to actually be much cheaper to run, and therefore, since it'll be cheaper, it will even allow more patients to utilize this technology. So I'm not sure when it'll be the change to that, but that's my guess in the next few years, because it's going to work better, it's going to be faster, and it's going to be cheaper. It'll probably be the platform that we go to looking at this. So when is the best stage to biopsy an embryo? Is it a cleavage stage embryo, so a day 3 embryo, or is it a blastocyst, a day 5, 6, or sometimes day 7 embryo, where you take some of the trophectoderm cells, so cells on the outside that are destined to become the placenta? So just quickly with trophectoderm biopsies, when you do a trophectoderm biopsy, so blastocyst biopsy, you're getting a lot more cells to analyze. Also, these are more viable embryos because these are embryos that have subsequently, divided and progressed, more days. So therefore, there are embryos that have been weeded out, so they're better quality embryos. They seem to be more accurate. So there was a nice study published in Fertility and Sterility a few years ago that compared cleavage stage biopsies to a blastocyst biopsies. And it was a randomized paired clinical trial. And what they did was they randomized patients to either a day 3 biopsy or a blastocyst biopsy. And each patient in this study had 2 embryos transferred back, so it was a double embryo transfer. However, none of the results of the biopsy were known until later on. So each patient had 2 embryos put back. One of the embryo, was the embryo that was biopsied either on day 3 or day 5, and the other embryo was the control embryo. So each patient served as their own control, had 2 embryos put back, the results were unknown. And what they did was, if they got pregnant, they did maternal serum sampling and did DNA fingerprinting to determine which embryo implanted. Was it the control embryo, or was it the embryo that was biopsied? And what they found was that a trophectoderm biopsy had no meaningful impact on the developmental competence of the embryo as measured by implantation and delivery rates. So, the embryo that was biopsied did as well as the control in terms of implantation. But the interesting thing was that a cleavage stage biopsy resulted in about a 40% reduction in the probability an embryo would implant and progress to delivery, therefore showing that the biopsy of a day 3 embryo was actually more detrimental to the chance it would result in implantation. It was more harmful. So here's actually a video of what a trophectoderm biopsy looks like. So this is a day 5 or day 6 embryo that's hatching, and on day 3, assisted hatching is performed with a little flip made in the embryo to help it hatch. And using a suction pipette, some of the trophectoderm cells are sucked into the catheter, and then using a laser with small pulses, you're able to separate the cells. And these cells are then sent to the genetics laboratory to be analyzed. So when you have a chromosomally normal embryo, the chance of it implanting is about 60 to 70%. So as we all know, that twin pregnancies, and obviously triplets or more, but twin pregnancies have increased neonatal and maternal morbidities. So how can we prevent those type of pregnancies? So the best way is to only put back one embryo. The best way of maximizing chance of conceiving with a single embryo is, screening it. And if you have a chromosomally normal embryo with high implantation rates, that maximizes the chance of getting pregnant from a single embryo transfer, and therefore preventing the chances that, and the complications from a twin or higher order multiple pregnancy. So there's also a nice study published a few years ago in fertility and sterility that looked at single euploid blastocyst transfers. There's also a randomized study. And what they found was that a transfer of a single screen embryo, so a chromosomally normal embryo, had an equivalent pregnancy rate as transferring two unscreened embryos. So putting back one screen embryo, same success rate of putting back two unscreened embryos. The important thing here is that when you put back two unscreened embryos, the multiple pregnancy rate, the twin pregnancy rate, is over 40%. And in this study, you didn't have any twin pregnancies with a single embryo transfer. As one would expect, it would be very low. Occasionally you put back one, and occasionally it could split, but it's very low. So the take-home message here is that putting back one screen embryo has equivalent pregnancy rates to putting back two without the risk of the twins. So that's what we're trying to avoid. So this was commonly known as the BEST trial. And what they concluded and demonstrated was that altering embryo selection by choosing a single chromosomally normal blastocyst for transfer results in ongoing pregnancy rates that are not inferior to those attained when transferring two blastocysts with an unknown chromosomal complement. And given the reduction in the proportion of multiple pregnancies, the long-term outcomes from this treatment paradigm are likely to be safer, resulting in fewer maternal and neonatal complications. So there are also some good data demonstrating better obstetrical outcomes in conceptions following transfer of cryopreserved embryos. And in the past, it was commonly believed that patients did better in a fresh cycle compared to a frozen cycle. Nowadays, because we've improved the way that we freeze embryos with a process called vitrification, which is the same way that we freeze eggs, patients do as well or even better in a frozen cycle compared to a fresh in terms of pregnancy rates. There's also some data, like I said, that demonstrate that there might be less obstetrical-related risks, because some studies looking at fresh cycles show that even singletons born through a fresh IVF cycle may be a little bit smaller or deliver a little bit earlier. And you don't really get those slight increased obstetric-related risks in a frozen cycle. And the theory behind that is that in a fresh IVF cycle, the patients are taking the stimulation gonadotropins, stimulate the follicles, make a lot of estradiol. And the thought is that high estradiol environment in a fresh IVF cycle may influence implantation and therefore development of placenta. And maybe the placentation is what causes that slight increase in obstetric-related issues. In a frozen cycle, you don't really get those high estradiol levels. The estradiol levels are more natural, so you don't really get those high levels. So maybe that's what is reducing the slight increase in obstetric-related issues. In the future, we may be doing all frozen cycles, and usually when we do CCS cycles, we'll bring them back in a frozen cycle, which I'll get to later on. But we're not quite there yet, but it wouldn't shock me in the future that all transfers will be frozen embryo transfer cycles. And there's also, excellent data from randomized studies demonstrating equivalent pregnancy rates upon transferring of fresh or vitrified, so frozen, screen embryos. So as one would expect, the number of embryos available for biopsy decreases with advancing age. So the older that a patient is, they're more likely to have less embryos available for biopsy. Also, as one would expect, there's an increased rate of aneuploidy with advancing maternal age. So the older a woman is, the more likely to have an aneuploid embryo. The other interesting thing is, the older a woman is, the more likely that the embryo will have multiple abnormalities, not just one. So it's very important, to counsel patients in terms of expectations, what to expect, relative to how old they are. So you have to remember, whenever you do IVF, not every egg you get is a good egg, not every egg results in fertilization, not every embryo continues to grow and divide. So this is data representing embryos that are available to biopsy on day 5, day 6, and occasionally we'll grow them out to day 7. So women under the age of 35, little less than 70% of the embryos will be chromosomally normal. This is, on average. Women 35 to 37, a little under 60%, 38 to 40, about 43%. Women 41 to 42, drops all the way to 25%, and women 43 or older, 15%. So it's important for patients to realize what their chances are of having a normal euploid embryo. There was another study published a few years ago looking at the error rate after putting back a chromosomally normal embryo. And this study uses the same platform that we do, the qPCR. What they found was the clinically recognizable error rate with CCS was real but quite low, and they had a less than 1%. It appears to be mosaicism and plays a prominent role in these misdiagnoses. What I tell patients is, I think this is a little bit low. I tell them it's probably a few percent the error rate, so it's an excellent screening tool, but like any screening tool, no screening tool is perfect. So because of this, we still recommend doing, the nucleotranslucency, the blood test, they could do a CVS. I don't think most patients go the CVS route, or even amniocentesis. They want just to confirm it. So it's an excellent screening test, but all the screening tests, nothing's 100%. It's very good, though. So what is a typical cycle like at a program? So our patients take, the gonadotropin stimulation medications. We follow them every few days with bloods and ultrasound, and then when they have a few follicles of good size, they then take what we call the trigger shot. And just a little bit of a side note, what we're doing, with these trigger shots, we're able to actually prevent hyperstimulation. Most of our cycles involve a GnRH antagonist called cetrotide or ganirelix. And in these cycles, you're able to trigger the final maturation with what we call a dual trigger. So instead of using the traditional HCG only, they receive low-dose HCG and Lupron. And in these antagonist cycles, the pituitary is still responsive to the Lupron. So that results in an endogenous LH surge, so they're making their own LH. And this special trigger shot, it results in immediate luteolysis. So they get the burst of LH, then all of a sudden the pituitary starts making any endogenous hormones. And that results in less stimulation of the ovaries, and they make less endogenous hormones and things like cytokines like VEGF, which has been linked to hyperstimulation. So majority of our patients who are anywhere at risk for OHSS, we trigger them with a dual trigger, and you get, OHSS is very rare, but it makes something that's very rare even rarer. And we're doing this to any patients at high risk for OHSS, or any of our, our egg donors, patients who have high AMHs, they're very young, they have PCOS, they have a lot of follicles, they have a high estradiol level. We're triggering them, with the dual trigger. Sometimes we will, if their estradiol level is very high, we'll even just use Lupron only. Patients do just as well, and we get rid of the OHSS. So it's a nice little trick we have now to prevent that. So they receive the trigger shot. About 36 hours later, they undergo the egg retrieval. When we do, our CCS cases, any patients undergoing these cycles, you always do ICSI, or intracytoplasmic sperm injection, as opposed to standard insemination. And the reason for that is if you did standard insemination and then you went to go biopsy the embryo, the sperm that didn't penetrate the egg, their DNA could potentially contaminate the results. So whenever we do CCS, we always do ICSI, regardless if there's a malfactor or not. We then culture the embryos out, and then we usually biopsy the embryo on day 5 or day 6 and freeze them. Technically, you could biopsy the embryo on day 5 and put the embryo back first thing in the morning on day 6. There's a very narrow window when the endometrium is receptive for the embryo. We don't do that often these days anymore for a few reasons. Number one, it's more stressful for the patient because they have to come in very early on day 6, before 8 o'clock. We don't know if we're going to have an embryo that's normal until they come in. So it's more stressful. Am I going to have an embryo to put back? Am I not going to have an embryo to put back? The other thing is we find that the pregnancy rates are better in the frozen cycle. They actually do better. So because of that, we biopsy and freeze the embryo and then send it to the genetic lab to be analyzed. And it takes a little less than 2 weeks. Lately, it's been a little more than a week, so they've actually shortened the time frame. And the other thing is we've learned that in older women, the embryos actually grow at a slower rate. So they're actually may not be ready to day 6. So the younger women, they may be ready more around day 5 for the biopsy. Older women, it takes a little bit before the embryo is ready. So we freeze the embryo, we send it to the genetic lab, and then what we do is, when they get their period, which is a little less than 2 weeks after the retrieval, and sometimes it's even quicker, because when you do the dual trigger, they tend to get the period a little faster because there's more quicker drop in hormones. So we start them on estrase, so oral estrogen pills, to start getting the lining ready. And then we get the results. Best case scenario, we have a normal embryo. We then decide when we're going to do the transfer, and then we start them on the progesterone accordingly. And then we put back one screen embryo. So here's some data from our program looking at pregnancy rates, putting back a chromosomally normal embryo over the last few years. So the key is when you have a screen normal embryo, whether you're 43 or you're 25, the chance of it implanting is the same. It's just harder to get to that normal embryo in older women. So what I tell them is, we do very well, but sometimes you might have to try a few times in order to get that normal embryo. It might take more than one cycle. It may take 2, it may take 3. It's nice when it works the first time, but sometimes, it takes a few cycles. And a lot of it depends on, their ovarian reserve, their AMH. I have 42, 43-year-olds who have high AMHs, and, you actually don't have to stimulate them as hard as you would as a 42-year-old who has an AMH less than 1. So the utilization of comprehensive chromosomal screening results in increased implantation and ongoing pregnancy rates, enhanced utilization of single embryo transfers, decreased incidence of multiple gestations, a reduced time to pregnancy, and a decreased incidence of miscarriage. An accurate diagnosis and enhanced safety with a trophectoderm biopsy at the blastocyst stage has resulted in increased implantation and delivery rates. And the ability to prevent aneuploid pregnancies allows patients to avoid the physical as well as emotional suffering of a miscarriage, and is truly a more patient-friendly approach. So who do we offer, comprehensive chromosome screening, or CCS, to, embryo biopsy? Well, I want to say about over 60% of our patients doing IVF are, undergoing an embryo biopsy. And I want to say women over 35, I don't know the exact numbers, but I'd say it's probably over 80%. So you got to remember, in women older than 35, the recommendation is to put back at least 2 unscreened embryos. That puts them at risk of miscarriage. So we recommend to all our older patients, to do this kind of, cycle. The other thing is, we see a lot of patients who have, one child and only want one more child. And, they find, this appealing because they only want one more child. They want the risk of multiples. And they do also have the option of, selecting the gender. If, they have a boy, they could choose a girl, a female embryo. A lot of patients don't want to know, but they do have, that option. The other thing is I see a lot of patients who are 40 who have no kids who want to have 2 kids. So they did a cycle, they got pregnant, and they had nothing left over that was frozen or unknown, and they come back 2 or 3 years later, they have nothing left that was frozen. It's going to be much harder for them to come back and get pregnant with number 2, or say they get pregnant, and say they have one that's frozen, and we don't know if it's normal, and they miscarry from it, so the high rate of aneuploidy, they have to start over again. So what we're doing a lot in those cases, I always ask my patients, what's their ideal family unit? A lot of times I'd just be happy with one, but I ask them, ideally, what would you like your family structure to be? And if they want, 2 kids, the goal is to have 2 or 3 normal embryos before putting back the first embryo. Therefore, kind of banking, maximizing, their future success rate. So, if they only have one after the first cycle, before we put that back, we may do another cycle to try and get that. In women under 35, I said right now we're putting back just 1 embryo. So I let them know that this technology exists, but I don't necessarily push it, or unless they have a history of prior failed cycles, prior implantation failures, recurrent miscarriage, or say they're young, they're 30, 31, 32, but they have a low ovarian reserve. They have a very low AMH. So in those cases, I also suggest that it may be beneficial to do it because, imagine they say they got pregnant, they have nothing frozen, they come back 2, 3, 4 years later. It may be harder to get number 2 because the ovarian reserve is only going to get worse. Or even if they have an embryo that's frozen, it's unknown, it's not as reassured. So in those, in those cases, unfortunately, we see a lot of them where they're young, but they have, low AMHs, high FSHs. If they want to have 2 kids, or say 3 kids, we want to get enough embryos to maximize their future chance of conceiving, in the future because it's only going to get worse. So we're starting, to bank embryos before we put back 1, depending on what their ideal structure is. The insurances don't always allow it, when it comes to that, and there's one that doesn't allow the banking. If you have a normal embryo, they make you put it back. So that sometimes the finances, don't allow patients to do what they want in those cases. Any patient who has a medical contraindication to getting pregnant with twins, someone who's had preterm labor before, cervical incompetence, another reason to put, the benefit to only get pregnant 1, medical contraindications. If we're trying to prepare a patient for surrogacy, you want to put back 1 embryo in the surrogate, especially if they're older. Then you're screening the embryos. I had a patient recently who was using the sister as the donor, except the sister was 38, 39. So not the ideal candidate, but they really wanted to, keep the genetic relationship. So in that case, we screened the embryo. Actually, in her case, and she wasn't even the best candidate. She had a low AMH. Her AMH was normal. She had an FSH of like 13. She had 2 kids, so she had proven fertility. Her youngest was like 2 years old, not the best follicle count. She didn't do great. We only got a few eggs from her. Biopsied 1, it was normal. It's actually a sad story because this patient, she's 43, she had a FSH of over 20. She got pregnant spontaneously during her sister's stimulating, halfway into it, and we spoke about continuing on with the cycle, knowing that her risk of miscarriage is still pretty high. So her pregnancy, long and short, developed very slowly, and I can't remember if she had a heartbeat and lost it, or I don't think she never developed a heartbeat. And this actually happened a few days before her wedding. So she actually had a DNC 2 days before her wedding, and 4 days before she left for South Africa on her honeymoon. And we actually got the results of her sister's, the biopsy, and it came back, euploid. Now she's gonna, she has that embryo. We're gonna put it back, I think, in the next month or so.
They only had 1.
They only had 1. I mean, she wasn't the best candidate, but we got 1. And a good one, and she was away when we found out the results. She didn't want to know the results. So,
Matt, looking at your rates, once you've moved out the aneuploidy, they look pretty steady, around 70–75%. What do you suppose the reasons or not getting pregnancies and the other 25% are?
So it's an excellent question. We don't, you would think that, like I said, the implantation is about 60 to 70%. Why is it not higher?
Right.
We don't know exactly. There's probably something else about the embryo, that we just can't test for, things like microdeletions that are probably responsible for, the other percentage not implanting.
Maybe other structural abnormalities that don't show up on the genetic testing.
Well, there's something else probably about the embryo, because it's less, or is it the uterus? But, we're screening the cavity, is it the uterus responsible for the rest? We don't know. A lot's going into implantation. Everything's very timed. So I think it's probably less likely the uterus, or maybe there's a subset of patients where there's something involved. But it's probably more the embryo, and we just don't have the technology to detect microdeletions that are responsible for, I guess, the embryo attaching or something going on with the implantation. That in the future, maybe once we link it to then test for it, which will then increase the 60–70% to much higher.
With the next generation testing, will we be able to do microarrays?
I'm not quite sure. I mean, it could, which is nice, look at translocations. It could, look at mitochondria, do a lot of things simultaneously, which right now you have to do different platforms. It's a little more cumbersome.
Right. Because the rate of microdeletions or microduplications on microarray in second trimester babies has been shown to be about 6%. So you could postulate.
It's even higher. That's even double.
20–25%, and that's your reason for your failure of a set 25%.
Yeah, once we start doing that more, then analyze, get more information. It'll see whether or not that further increases. I mean, you may have less to put back, but you'll go from 60–70 to 80–90.
Yeah.
Since you're screening trophoblasts, are you recommending amnio over CVS or traditional serum screening over NIPT for secondary screening?
So usually what I'm telling them is, like I said, it's an excellent screening test, but nothing's 100%. Usually when I see miscarriages from, following, these cycles, it's more of a biochemical pregnancy. It, very rarely does an implant. So they don't even get that far. This can't detect for triploidies. That's, because there's an equal amount of genetic material, so it doesn't have, but those are very, very rare. So we're still recommending them to do the nuchal translucency, to do the blood.
That's not my question. Both CVS and NIPT are also testing, well, they're also testing trophoblastic cells. So if you've got a confined placental mosaicism, where it's the placental cells that are normal and the fetal cells that are abnormal, you're going to get the same error on your diagnostic or screening test than you are theoretically if you use, instead of using CVS or NIPT, if you use traditional serum screening and amnio.
But the difference, the big difference, though, I think, is you get a lot more cells to analyze. So you're getting a few, you get, compared to day 3 biopsy, you get a lot more cells. But when you do a CVS or amniocentesis, you have a lot more to analyze.
Not addressing the confined placental mosaicism issue.
So that's one thing, that you can get confined placental mosaicism, but it's not, so far in our experience it hasn't been that common. But because of the false negative, we still recommend them doing most. To be honest, I don't think do more than nuchal translucency in the blood, and I don't think many do CVSs. I don't think many are doing the amniocentesis, are going that route. Some patients who want the the definitive will go that, but I don't think that's the majority.
What percent of mutations are doing the speech genetic test?
So I think over 60% of our cycles are doing that, but it's more. I think it's about 60%. I think in our older couples, the women over 35, I want to say it's about 80%. And the women and the couples who are not doing it, it's the finances. So it's about $5,000 to do the cycle. So so it's $5,000. It covers the biopsy plus to be analyzed.
What about the ICSI?
So the ICSI, so ICSI is extra, unless so a lot depends on the insurance if they cover it. The insurances don't cover the biopsy yet. In the future, I think they will cover it for a few reasons. Number one, it's actually cheaper, to pay $5,000 up front than pay the $100,000 from the twin pregnancies. So it's actually much cheaper for them.
3 extra cycles from the aneuploidy.
Or for the extra IVF cycles that they have to do in the future for failed cycles, for miscarriages. So it's actually cheaper. So I think in a few years, they'll probably the ones that cover IVF will probably cover it. In terms of, so if they had no coverage, or say they had some patients that have IVF coverage, but they want to prove the ICSI, for example, United, or such as United or GHI, unless they have like a severe malfactor. So if they don't cover the ICSI, it's $2,500 additional for that. So a lot, we'll have the ICSI covered, so they only cost them $5,000, but if they, so.
What's the ethical issue in terms of sex selection? And what the patient proves if she has employed AB or the opposite sex? So,
we have patients who will do it, only want to put back a certain gender. I want to say that's, we do have that. That's less common. But they won't put it back. They'll discard those embryos. Most patients, don't actually want to know the gender. When you look at the majority, they don't want to know, or they say, you know what, I have a boy at home. I prefer a girl. If I don't get the girl, I'm okay with it. But we will do IVF with gender selection. We do offer that. Not all programs do that. Because it is an ethical dilemma. If you have an undesired gender, about discarding it. But large majority of patients who are doing this, even if they have a child, I tell them they can find out the gender, but their response is, I just want the best embryo. I don't care. And some of them say, what, don't tell me. If I get pregnant, then you can tell me. They're all different how they go about that.
So do you, for example, if a patient comes in and says, I want 3 children, you try to limit the number of eggs that you get from her so that she doesn't have to discard the embryo? Now, I think that must be a difficult thing for a person who has problems getting pregnant anyway, to discard the 25 embryos that are left. Like, patients who are also donated.
Most donate. The problem with embryo donation, there's a lot of guidelines about that, so it makes it hard. We don't offer embryo donation. Most programs don't offer it because there's certain FDA guidelines about having to retest 6 months after, so it makes it very cumbersome and not friendly. It's not as practical. So, usually there's a few Christian agencies like Snowflakes, who you could donate to them and they take care of that. So embryo donation is not that big. Very rarely do you have a ton of leftover, embryos. You got to remember, we stimulate the patient based on certain parameters, the follicle count, the AMH. So a younger patient, you're not going to stimulate as aggressively. So they're not, they
add X number of.
So you may not get as many, or sometimes.
Okay.
No, I'm going to sleep. I'm fine.
Okay, sit down. Don't get up and do that.
Matthew here will take care of it.
You sure?
Just let me out.
You want that leg out.
So sit down and let it wake up. You can stretch it sitting down. So, occasionally, so you will have leftover sometimes embryos, and sometimes, patients say, I want 1, and then they change their mind in the future to 2, so they have the option. Recently I had a patient who was 38, only wants 1 child, had a high AMH, and I told her I'm not going to, stimulate you super aggressively because you don't want to have, more than 1 child. I want to stimulate where I'm going to get enough and maximize your chance of, you want to have more than 1 because, like I said, it's not 100%. So you want to have minimum, 2 to protect them so they don't have to do another first cycle. But, very rarely have I seen, patients with, a boatload of extra euploid embryos. But the PCOS sometimes are funny to stimulate because, some of them require actually nothing to stimulate them. Some of them, may require more than one would expect. There's some are very, very brittle. And just because you get a lot of eggs, patients will get 20, 30 eggs, and you don't have many embryos at the end. And then you have patients who get 6, 7, 8 eggs, and you'll biopsy 3 to 4. It's not always the quantity. Plenty of patients who I got 20-something eggs and only had a few left, to work with. And then there's some you get even 3 or 4, and they get out of those they get the biopsy too.
Thank you.